So welcome to the final session of day 2 of RIO 2025's global program. This session is called Epicardial VT Ablation, Mapping and Access Techniques, and it's a live case session from Tung and his team at the University of Arizona College of Medicine in Phoenix, the US. Before we go over to Rod, I'm delighted to welcome our panel, Usha Tedrow from Boston, Krishna Pothineni from Kansas City, and we're also very happy to be joined again by our course leader, Devi Nair. And I want to remind the audience to please keep sending in your questions. They obviously make my work a lot easier because you give me good questions to ask the panel, but we love to have your interaction and engagement. So we're going to go to Rod in a very short while, but before we do, what I'd really like to do is to ask our panel about their experiences of epicardial ablation. And perhaps I can start with Usha. Which are the patients that you're expecting to have to do epicardial approaches for? And what's the sort of characteristics for them?
Thank you for having me on this great session. I think that there are a couple of different types of patients that we consider for epicardial access. In particular, patients who've failed an endocardial attempt at VT catheter ablation before is always somebody that will be thinking about whether to do epicardial or not. Non-ischemic cardiomyopathies of different kinds will sometimes have more likely epicardial substrate, in particular those who have like an infralateral or infraposterior substrate that we could see on imaging. I do use imaging a fair amount, either MRI or CT, to try to figure out where the scar substrate might be located. The patients with non-ischemic cardiomyopathy that might be less likely to have epicardial substrate might be those with more septal or anteroseptal substrates. Those would be a little bit less likely to be accessed from the epicardial space.
And I'm going to come back to you on that imaging question, but maybe I can ask Krishna, what's the pre-procedure imaging that you do, and how does that influence your approach to the patient when they come into the lab, Krishna?
Yeah, that's a great question. Thanks for having me. The pre-procedure imaging of choice is either a cardiac MRI or a cardiac CT, depending on the patient's condition, if they can tolerate an MRI. And we also have a lot of imaging processing softwares we try to incorporate into our pre-procedural planning, such as InHeart or ADAS, to try to identify areas of wall thinning or areas of channels that could present isthmus circuits for the VT. And we try to incorporate these pre-procedural imaging characteristics into our procedural planning.
Yeah, tell me a little bit about those, because I think that the 3D mapping companies have not exploited them anywhere near enough. I think they're pretty valuable bits of technology. How does it make a big difference to your procedures, Krishna, to use ADAL or similar technologies to try and show you during the case where everything is?
It definitely does. It helps with identifying areas of potentially even functional substrate that you can pick up even on pre-procedural imaging. Additionally, it also gives you a lot of information about relevant regional anatomy that you can use to your advantage during a case. For instance, if there is epicardial circuit and InHeart can show you that there's a coronary vein that goes very close to where the circuit is, you could potentially change your approach to infuse coronary ethanol based on the anatomy information that you get. So I think the imaging from InHeart and ADAS has a very important role to play that will shorten the overall mapping time. We don't have to keep patients in VT too long and precipitate hemodynamic instability. I think all those things can be better managed with better planning.
Devi, can I come to you and ask you how you approach the epicardial space? What techniques and technologies do you use to get into the epicardial space safely?
It's a great question. So I will say, full disclosure, I don't do ischemic VTs anymore. I'm here more to learn from Usha and Krishna and Rod, and hopefully help you with questions, because I have a lot of them too. But I do access the epicardial space for other reasons, for mapping, for the atrial substrate, as well as for LAA management. And in those cases, in some cases, we'll use EPIs, which is a video thoracoscopic, video-assisted tool that lets you kind of get access and visualize the pericardium. There is a device called Pericross device that we've used, which gets you into the epicardial space, and you could apply vacuum and pull up the pericardium off of the RV and puncture. And then we've also accessed the pericardium through the right atrial appendage or through the CS by puncturing the appendage or the CS. So these are kind of the techniques that we have used. I'm sure Usha and Krishna have more experience with that. For me, getting to the appendage, this is more than enough.
Okay, yeah, fair enough. Well, you do plenty of different things. I'm not so surprised that you're at least human and don't do absolutely everything. Usha, tell me about your approach to accessing the epicardial space.
Yeah, I think it's an imperfect procedure. It's looking for its moment to make it safer. I feel like there was this moment in transeptals when we got ice and a couple of other things, but ice in particular, that made transeptal puncture like not as stressful as experience as it was kind of 20 years ago when I first started. And epicardial access is definitely waiting for that. I've tried the EpiEase device, and I'm not. My experience was that it didn't like totally alleviate that difficulty. I think the CO2 insufflation has a lot of promise in terms of making a little bit of space for us to get in and trying to reduce the risk of the procedure. The other thing that CO2 insufflation has the benefit of doing is diagnosing adhesions before we even try to get access. So if the CO2 doesn't evenly go around the pericardium when we do our insufflation, then you might try a little bit to get in, but you might be aware that there might be adhesions and things. I would put a plug out there for getting pre-procedural imaging to look for any anatomical differences that the patient may have, whether it's a pectus excavatum that may change your approach to the pericardial space. Sometimes people with that, even the liver will cover the whole area that you'd want to go for access. And you just want to see what all the other little anatomical things that might be there. Patients who've had, say, a gastric bypass procedure or something like that, the abdominal organs may be in a place that's in your way that they wouldn't be normally. So all of that kind of thing can be explored with imaging beforehand.
And can I just ask you about the adhesions? Because, presumably it's still possible to get in and break up those adhesions with an ablation catheter. So would there be anything on something like a CO2 insufflation that would make you think, I'm not going to bother, it's just too tethered?
I'll tell you what my approach is to that. As you know, the folks that have some adhesions there, the problem if you get through and push around with the ablation catheter to get in, there's a possibility that you might have bleeding, and then a surgeon would have to potentially get in there very quickly, and that can be a little bit of a difficulty if there's already adhesions in place. What we've done at our institution for patients that have that kind of situation is we have a very talented thoracoscopic surgeon who's able to, with a very minimal port placement strategy, get in there and actually peel away some of the adhesions and get our catheter into the pericardial space. And that's very safe, and the patient can recover very quickly from that kind of procedure.
Yeah, so one of the things that I used to focus on an awful lot was the position of the coronary arteries, and I was pretty anxious about it. And I have to say, as time has gone on, I've got less and less obsessed about them. I guess because it's pretty unusual that you cause significant damage, or at least that's been my experience. And obviously in patients who have an ischemic VT, you're dealing with an area where the coronary arteries aren't, really, it's massively significant anyway. Am I being too relaxed, Krishna? Should I pay more attention to the coronary arteries and their position when I'm thinking about ablation?
Yeah, I think it's a very important point when we when we are about to start ablating in the epicardial space, that we are at a safe distance from major epicardial coronary arteries. Like you mentioned, Richard, if you have a patient with an inferior infarct and we do a coronary angiogram and the area that you need to ablate is only supplied by very tiny branches of the PDA or the PL, it is often okay to sacrifice those branches that supply an infarcted area and try to ablate more deeply. But if you're talking more proximal coronary arteries, I would be more hesitant to ablate when in close proximity. We always make sure we're at least greater than 5 millimeters away in at least two orthogonal fluoroscopic projections before we deliver energy.
Brilliant. So we've sucked all of the knowledge out of you, and now we're ready to go to Rod, who's ready for us in the EP lab. Over to you, Rod.
Well, we are delighted to be, I guess, closing out day 2 with you here. Dr. Schilling, we've got a really unique case of what we believe is Brugada syndrome. And we're going to proceed with our approach to a Brugada syndrome patient. But I'm going to have Dr. Fakhri first introduce the case. I need to give a shout out to Amy and Lawrence and Jason and everyone in the lab here, Miriam, our anesthesiologist, for doing a 1-hour turnaround from that cardiac neuroablation. I do want to report back to you, Professor Schilling, that we gave atropine and the heart rate remained in the mid to upper 80s. So that was very nice, and we were very happy with that case. So Dr. Fakhri, our second-year fellow, is going to introduce the case, and we will proceed after that.
Yeah. Hi, everyone, again. Amir Fakhri here in Banner University Medical Center, EP Lab 7. So for this case, a bit different. We have a 37-year-old male who had a history of cardiac arrest with reported Brugada EKG pattern and therefore received an ICD. And so he carries this diagnosis of Brugada syndrome. Interestingly managed on disopyramide. He has never tried any other antiarrhythmics such as quinidine. In the past few years, though, he has experienced multiple shocks. And at the same time, he has concomitant syncope during these events. We can go to the next slide. So this is his baseline EKG from 2023. You can see we have certain aspects of Brugada type 1 EKG. We have a pseudo-right bundle branch block. We have ST elevation, maybe not at 2 millimeters, but we do have T-wave inversion as well, deep T-wave inversion. And we can go to the next one. And so this is within our clinics, and you can see a kind of a more convincing Brugada type 1 EKG pattern with all criteria met. Certainly a much higher ST elevation, especially in lead V2. You can go on the next one. And so these are extracted from his ICD. These are his 2 events, and you can see on the right we have evidence of ventricular fibrillation with ICD firing. And then on the left, we have the initiation. And we can go to the next slide. And so these are 2 separate events right here. You can see 2 separate initiations. And we interestingly see on the lead that this is actually the RV tipped coil. We can see that both are initiated by a very similar local EGM PVC, small R wave, but predominantly S wave as initiating PVC. And so here we are right now doing our introductory survey of the LV and RV, and with some interesting findings. Dr. Tung wants to take over.
So it's important to differentiate Brugada pattern from Brugada syndrome. The patient presented with a type 1 pattern and was resuscitated during sleep for polymorphic VTVF. So I think this really does fulfill criteria for Brugada syndrome. Genetics are pending, and that's why he had already been, interestingly, on disopyramide, and we all know that quinidine, typically what's used, he's young and works in commercial electrical work and does not wish to be on long-term antiarrhythmic therapy and has suffered from 4 shocks, all, as we showed you, for polymorphic VTVF. So we believe this is the right indication for an ablation. You know, people have even pushed the envelope about trying to ablate earlier phases. But our plan was to show you and first discuss the 12-lead EKG. Why don't we just show live where we are here? Yes, we have V1 a little bit, one interspace higher, and V2. Can we go to 12-lead live? Great. And just showing you that there, it really looks like a type 1. It's not maximally coved. There's a little bit of a drop down, but there's 3 millimeters ST elevation, which fulfills the criteria for a type 1 Brugada there and some terminal T-wave inversion. So we feel good about that. We might want to think about giving procainamide, which we've prepared for, which can exaggerate the abnormalities and give you a real, J-wave, very coved type, because this isn't maximally coved. One thing that we're looking at here on ice, and why don't we go full ice, Chris, full ice. This is an image of the RV, and it's quite enlarged. It's globally a little bit hypokinetic, but as we get into the RVOT region here, you can see that the anterior portion has a little bit of aneurysmal dilatation. It could be my imagination, but there's a little bit of an outpouching there on that anterior RVOT. And when I was a fellow, people talked about overlap between ARVC and Brugada. There's been biopsies of these regions that show that there could be fibrosis or fibrofatty, but then you can get a Brugada manifestation. Could this be an overlap of this? But ARVC does not typically cause polymorphic VT and VF at night. So I think the phenotype is still more consistent, but it's interesting to think about the structural abnormality that we're associated here. What I was planning on doing before we go to the panel was to do a little bit of endocardial mapping here in voxel mode with a grid and just touch down at that endo, because the beauty of Brugada is to opine about the transmural dispersion across the epi and the endo and take a look if there's any endo abnormalities in this area. And then we were going to do the stick live and get epicardial access and then examine the epicardium there, plus or minus procainamide. That was kind of what our plan was for the day.
Yeah, Rod, that ice image looks really good. It looks like there's paradoxical motion in that aneurysmal area in the outflow tract, doesn't it?
Mm-hmm. Any thoughts from the panel if this is not Brugada syndrome or anything, or everyone feels pretty good about this being Brugada, and how often we see structural abnormalities with Brugada there as well?
Well, it's interesting. I was wondering
Good.
if I could ask, this is Usha,
Good RIO.
was there an MRI of the patient? You might have mentioned that during the case and I missed it.
No, there was not yet an MRI, Usha.
It's interesting. That could be helpful.
And we've actually been slightly disappointed because there are cases of ARVC, because the RV is so thin, signal intensity not optimal, that are missed with ARVC with normal MRI. Give me RIO. Any other comments from the panel about this? It's not common in the U.S. to get a lot of these Brugada ablations.
We see,
can I ask a
certainly in
question,
the
Richard?
region of the world I come from, in East London, we see an awful lot of Brugada type ECGs because it's an ethnic appearance. But I think you're right that we seem to be seeing this signal of overlap between a cardiomyopathy and the ion channel abnormality producing the phenotype, which a pure ECG change won't produce. Devi, sorry, I stepped on you as well.
No, that's okay. No, I had a question for Rod
RAO.
or Krishna. Is it just my imagination, or is it something that I learned that the intracardiac EGMs and the signals could be dynamic in Brugada pattern? So I've always wondered. I mean, of course, before you start, I don't want to ask you what your endpoint is going to be, but what will be going after? Are we going after intracardiacs? Are we going after the pattern?
Yeah, I would leave it to Rod to decide what he's planning, but I would hope, there's some Brugadas where you can see there are these abnormal late potentials sort of in the free wall outflow tract region. They're usually predominantly on the epicardium, but there are definitely cases with similar patterns that are seen from the endocardium as well. And it's important that you have sort of safely but maximally kind of type 1 pattern so that you see the maximum amount of delay. If you can target those areas, it's been shown that the ECG can become normal. My impression has been of the 4 cases that I've done when they appear to have some kind of cardiomyopathy along with it, that it doesn't totally become normal after
Rotate a
even
little
when you
bit.
ablate the late potentials, but I don't know what others' experience is.
So
David, as
is
a
the goal to
clinician,
decrease ventricular arrhythmias?
Yes, but I think the goal is also the endpoint. If you look at the literature, like Nadamani's work and some of the work out of Italy, would suggest that you should try to get the ECG to be normal.
I agree with Usha based on what
Yeah,
I
so we're
understand
gonna
about
we're gonna shoot for
Brugada.
normalization of the EKG as well. Typically, when you do an ablation here, you'll get ST elevation during ablation. The mechanism's not clear, but maybe you're just releasing some ITO imbalance and you're actually changing where ITO is the highest density. It could be that it's structural disease here. But our goal will be to try to modify or eliminate abnormal electrograms in this region and then look to see its effect on the 12-lead EKG. Typically, you eliminate the J waves, you'll get a little bit of ST elevation, which is more rounded, like convex, and then everything is relatively normalized, even acutely. The inducibility to VF has also been shown that you can maybe easily induce VF. We might not do that today, but we might if the panel wants to urge that, because we've got about 40 minutes here. Right now, you can see on ICE that the tip of my grid is pushing into that aneurysmal region. And I don't see anything that's wildly abnormal. Why don't we go to the quad screen there again, Chris? Great. And why don't you go live electrogram, major, huge zoom, because EGMs are everything. And there you can see we're in this aneurysmal area, and that's one huge advancement, right? If you see something abnormal on ICE, you've got to put a catheter in as many electrodes in that abnormality. And until you're guaranteed that you're stamping out that region, then you haven't mapped the area. So right now you can see I'm kind of sliding above the aneurysmal part. But even on the tips of A1, A2, I don't see anything that looks highly abnormal. And on our voltage map here, why don't you go back to quad screen here? You can see that the purple region looks relatively normal by voltage here. So we're not seeing any discrete late potentials. We're at the pulmonic annulus above, so I would disregard all the gray there. But many people don't even map the endocardium for Brugada. They just go straight epicardial. And you can certainly argue for a minimalist approach and not even use ICE, not even use the CS catheter for reference, and not even map the RV endo, because the abnormalities have really been shown to be primarily epicardial. But for demonstration purposes, and because there's this weird aneurysm, I think it's nice for us to assess both sides. But I don't see much here in terms of electrograms. They're not telling us a story that there's really like late potentials or ARVC happening here. Although there's a little bit of low voltage in this region.
Are you able to display the unipolar voltage?
Yeah, let's do that. So why don't we go unipolar at 5.5, which is proposed by Pollen et al. From Penn, and see if there's anything abnormal there. And actually it looks okay there, Usha.
Mm-hmm. Cool.
Looks okay there. And this wall is just so thin that I'm not certain that those criteria have been validated in the outflow tract, obviously. But definitely worth looking at here and flipping back up here. So I think we've kind of done at least what the other side looks like. And while you discuss, I'm going to go ahead and go with an epicardial approach here.
Krishna, you had a point that you were trying to make earlier.
Yeah, in terms of endpoints, like Rod already mentioned, non-inducibility is also an important endpoint that was reported in Nadimani's papers. And sometimes we can even exacerbate the late potentials in the epicardium with a procainamide challenge while we map the epicardium. That has been shown as an endpoint as well that can potentially be used.
Why don't we make the floor?
Can I ask you guys what the progression of the pattern is? So
contrast.
Oh, like why the type 1 comes sometimes and why it doesn't
no,
come
no,
other
no,
times?
no. Like once you do the ablation, do you see it when the patient say comes back 5 years later? Do you see the pattern come back? Do you?
Usually
What's the
not.
progression? What's the
No, you
nature of the
see,
progression?
usually pericarditis right afterwards is typically the initial finding, and then several days later you can watch the EKG become completely normal, and it usually stays normal after that.
Keep talking.
I don't know, Krishna, if you have other comments.
Right point.
No, I agree. I mean, the normalization of the Brugada pattern is almost immediate post-ablation. You can actually have it as an endpoint at the end of the procedure. And over time, once the acute pericarditis resolves, I don't think it comes back again.
Let's focus on Rod because he's doing the stick now. Rod.
Yeah.
Go to RIO, please.
So, Rod, you're putting little bits of contrast in there.
I lost them completely.
The pericardium.
Yeah, so Dr. Tung, do you want to tell you what they're saying?
Mm-hmm.
Yeah, they're just mentioning that you're lighting up the pericardium with contrast right now.
Okay. No, that's interesting.
There's a little.
I think that needs to be shown. Did you guys see that we're actually doing a small hepatogram there? That even though I went very shallow, we're actually lighting up the liver a little bit.
Yeah.
Did everybody see that?
Dr. Tung's mentioning that
Yeah.
we've done a hepatogram.
That you can see there was a little bit of contrast that went in. So what I'm going to do is go even more shallow here in terms of our approach.
So more shallow in this approach.
Why don't we go to cross table lateral?
We can
Let's
hear
go to
him
cross table
talking,
lateral.
so-
I've lost my feed completely. If it's possible to replace.
Can you hear?
They can still hear me, right?
Correct.
Yeah, Dr. Tung, they could hear you.
So while I went very shallow in the initial couple centimeters, we were still in the liver, which is probably something that happens more often than we think. Obviously, liver biopsies happen routinely in interventional radiology, and patients typically do well. But the recognition of that and not putting a large sheath through it, I think, is the most important. So I'm going to reroute this to a more anterior puncture, which allows a very shallow approach to be able to see if we can get in that way. But I think this is good to be able to show some live epicardial access approaches.
So we'll notice that he's starting to
Are you
do
able to
like
hear me now?
table lateral type of
Yeah.
thing. Yep, we can hear you.
Great. Okay, but everyone saw that liver light up, right?
Yeah.
There was a little bit of like some hepatic sinusoids, et cetera there. Great. So that's a beautiful cross table lateral. We're going to go ahead and just cine that and then see what we've got here. Let's pull this out and then just see if we can sneak right under. And this is the way that people do it for Laria. And one could argue that an anterior approach makes the most sense for something like this where Brugada lives on the anterior RVOT. So let's go ahead and reroute. The key is to recognize that immediately. And what we're going to do is almost like a subclavian, go very, very shallow and try to go immediately underneath the sternum. So this will be a shallow, and now in the world of EVICD, that's increasingly more relevant there as well. So you can see I can't even get shallow enough, even though I'm directly under. Can we show my hands? Can we show? Okay, so you can see my hands. You can see I'm completely flat against the patient here. And on fluoro, you can see that I'm able to just get underneath. So we're really trying to keep that super flat as we come up this way. And I'm pushing down, almost pointing upwards. You can see I'm sneaking up under the retrosternal. Let's give a little puff of contrast here. We like the slip tip because then you can sneak it off, which is really critical here. And then see if we can get over this region. And you can see the heart contracting above us a little bit there as we're sitting there. Some cables are not ideally positioned there, but that's such as life. I'm going to give a puff of a little contrast here and see if we're entering the area. And there I felt a little something here. And then there we're tenting something pericardial, likely. And you can see there's some other region that's the inferior side of the pericardium, which is harder to see. So this has a strange contrast because it's not moving. So what I'll do is advance through this here. And then see if we can get through in this direction. But there's definitely something lit up, and sometimes there are these costophrenic ligaments that are a little bit tough to get through. Can I get just a hair more contrast here? We're definitely through some tough.
Got a very long.
We're still in this. Yes. And what I'm trying to do is get through this to be able to tent the upper portion of it. And we're not able to get through. You see, it's kind of creating a channel. There you go. And it just popped through something, probably like a ligament. And then now we're sitting in the pericardium. Let's see if we can wire this rapidly. So it got through, and this goes straight up anteriorly, which we love to see. And that feels good, but we want to make sure that it goes good in LAO too. So I'm going to take this needle out because of my wires in. And let's look at LAO. We're going to come back to there. So what happened is we got through this really tough ligament, and the minute we popped through, it actually pulled in the pericardium. You didn't see it, but I pulled the needle back just a hair to make sure it wasn't to the myocardium. Now, for all the learners in the audience, you want to make sure this wire is not in the RVOT. We have ice view, so we're not seeing a wire. We're not seeing ectopy as we move this, which is a great sign. We don't see anything on ice view, although we could be off axis. And in LAO, you can see this is a problem because you could be in the RVOT if everybody could see that. That is the course of the RVOT. So it's my job to prove that this goes lateral. And now if I push it more here, okay, let me see here. And I need more length here. If I push this here live on fluoro, there you go, okay? So everybody see that? So I'm just going to cine that because I think that's a very important teaching point for epicardial access, that right here, you don't know if this is RVOT because that's the course of it. And as I push the wire, I goes all the way to the left lateral border, and now it's safe to enter. Any comments from the panel there?
That's very, very important. And I think that on the ice there, when you're advancing the wire, you could actually see the wire in the pericardial space as well. So that's very reassuring. You want to look and make sure you don't see anything inside the heart.
I agree.
I think it's very
Now we're going to
demonstration,
double
right?
wire
If you
as well.
There's also a little bit of feel, as you said. There's a little give when you get underneath the diaphragm and into the pericardial space that people don't mention very much. So yeah, you made a really lovely demonstration of that. Krishna.
so if you have an inadvertent wire in the RV, what would your approach be?
Don't panic and get access on the way out. Don't just pull out because you're already in it. It's almost like a through and through arterial stick. You're already through it. Get it while it's still in, rather than puncture again. So what I would do is just pull back a millimeter at a time and try to rewire. And typically you can get in. Okay.
It's not uncommon in that
So I'm
situation
gonna
that
go
there might be
ahead.
a little bit of bloody fluid in the pericardium, but it should clear out fairly quickly. It's very uncommon that continues to bleed.
Yeah, and I guess the important thing is you're probing with the wire rather than putting contrast in as you pull back, just to find that space, eh?
Second wire. Second wire. So we always double wire.
Rod, how?
I think I've said this before in Rio, that once you get access to a privileged space in life, make sure your hand is stamped and you get re-entry. So here I'm just going to double wire this pericardium.
Rod, how often do you use a sheath and sheath approach?
Needle and needle, Devi, or sheath and sheath?
Oh, no, needle and needle. Take it back.
Yeah, so needle and needle is not something I was trained on. I'm still old school in that regard, 17 years out, that I wasn't trained with micropuncture. So what you give up with micropuncture is feel, but what you gain is a smaller puncture. So for those that are used to tactile sensations, like I felt I felt the diaphragm and I felt the pericardium as well. I don't think I would feel that with micro, but of course, if there's a mistake or a bleed, you're going to have a larger bleed there as well. So that is all a trade-off. But I think it's whatever you're comfortable with. I don't think we should be dogmatic about it. Pete Weiss does have this new Paracross system, which looks amazing. I was part of that, some of the initial animal work, and we're excited. And he's used that a couple times here already. So that's also exciting, which has a little bit of a grasper that pulls the pericardial sac, creates a little bit of space, and then the needle goes in, and the wire goes in. Sorry. So let's go ahead and we're just going to clip this off to the side, and then we're going to go right to the anterior RVOT with the 20 minutes that we've got left and start mapping that live, and then see what abnormalities we find. And hopefully we're going to see some long fractionated electrograms. Sometimes they're near field, sometimes they're far field. We can talk about repole versus dipole once that happens there. So now we're introducing a short Agilis sheath into the wire. We've got one pinned off to the side, so if we ever need. If you have large volume tamponade, double access is great because you're trying to prevent pericardial thrombus. So getting a dual evacuation with another, put one anterior, put one posterior, put one in the lateral recess of the RV, one in the lateral, just try to get rapid evacuation. Sometimes that's a really nice way to save yourself from surgery. So now we're advancing this up here. We've got 2 wires in the pericardium. We feel pretty confident about that. Here we see some transition issues here. So there we go. And as we move in the pericardium, just because you're over a wire as well, you've got to go very gently because you can still, spear the myocardium if you really push too hard here. So you can see I'm getting a little bit of resistance, and this is good because this is real world. And he's feeling a little bit of it. If we can give a little bit more sedation, he's under general anesthesia, which tells us that there is some sensation there in the pericardium. What I'll probably do right now, because there's a little resistance, is I'm going to take this back out and just run the dilator up and just pre-dilate this space a little bit. Because you think about it, we're very retrosternal, and we're trying to come through that ligament that we saw go through. And let's go ahead and just run a dilator up, and we'll put the Agilis up. Maybe we can go to the dipole repole conversation and have that preemptively whenever we're describing the abnormalities we see in Brugada.
Usha, do you want to cover that topic?
I'm not sure exactly what Rod's referring to, but I think he's one of the things that we want to think about is when we're mapping is that we're going to be looking for abnormalities that correspond to the areas where the ST elevation is often seen in the surface ECG. So when we look at the late potentials that we see in the lateral outflow tract, they usually correspond to that area. I'm not sure what he means by the dipole repole thing exactly. Krishna, do you know?
I'm not sure either.
Well, I'm glad that we all speak a different language.
I know. Well, in some ways, it's different than the substrate that we sometimes look at for structural VT, right? We're looking for late potentials that are a part of the QRS complex, and the late potentials that we see, say, when we have a large infarct and we see potentials that are wandering through a channel after the QRS is over, they're not part of the repolarization. They're actually the residua of the depolarization. And in this case, we think that it's actually part of the repolarization phase of the QRS. So if I had to guess, that's what I would think that he's talking about.
And Rod referred to the use of drugs like procainamide to try and bring out these abnormalities. How often do you and Krishna use drugs to highlight the changes?
For me at the outset, I typically would only use them if I didn't have a type 1 pattern. If I already had a type 1 pattern, I wouldn't start with administering a sodium channel blocking drug. But at the end, once you're done ablating, you could administer those drugs to see if you could reestablish a Brugada pattern if it was controlled. Krishna, what do you think?
So my experience with Brugada ablation is an N of 1, and I use procainamide in that case, just to make sure that we got all the endpoints.
I think the one risk is just that if you already have a full type 1 and you give additional sodium channel blocker, there's a chance that the patient could go into a VF storm from that. And so you want to make sure that they stay stable for all this stuff that we're doing here up until the point that you're ready to do your ablation.
I think I'm back and I can hear you. We just did a pericardiogram. If you can show the entire fluoro and just replay that. If you love anatomy, which is all of us, it's so beautiful to see a contrast pericardiogram because you can see the great vessels and everything. If we can play that here, Amy, if you guys can replay the fluoro. Just play this here. There you go. Live. See that? And you can see where the great vessels are. You can see where the RVOT is. It's so beautiful. And you can see the left atrial appendage up there in live. So you can see we're right over it, which is beautiful. So we're going to come out with the grid here and hopefully expose some of Brugada's beauty here. Go ahead and come back to AP. And I was just in Yokohama and had the pleasure of being with Dr. Brugada, who gave 35 years of Brugada syndrome and insights into that. So it's incredible how long these insights have already been made here. So here we have a grid catheter out. We're over the epicardial RVOT. Voila, fantastic. So here we're going to start mapping our first position. Let's go big on the live electrograms. Let's go big on the live electrograms and look at those signals. That is pretty characteristic. Very high frequency at the initial part, but then as Usha was saying, you get this J wave, a local J wave. Look at A1 and A2 that is under the J. And that really doesn't seem like a dipole abnormality, but obviously you can't get repole without dipole. So this age-old question will always be asked, but we're going to move around a little bit. Let's go to here. We're moving right over, and we can go to the mapping screen. You do have a lot of fat over this epicardial RVOT for anyone that's been in the OR. So you're going to see that there's this, but we didn't see this on the endocardium with these sort of abnormalities. This mapping is very localized. And as Usha said, you can even see live on the ICE catheter, you could see us in the pericardium. And what we'll do is just make a very localized map here that was famously shown by Nadamani in 2011 in Circulation, which was a localized RVOT map. So we'll do our best to emulate that here. And you can see, look at that. It's quite abnormal here. Let's park it there, right there. Very complex electrograms. And this is much wider of an area than we were thinking of just over the RVOT. We're just doing real mapping in real time. It's important that we constantly are screening the electrograms.
It's striking how small a distance you cover to have a very, very delayed electrogram. It's really striking. You're hardly moving at all, and then you've got that very, very late patch of activity.
Mm-hmm. And look at these. Look at these as we move up here. Significant abnormalities. But as you know, with Carlo Papone's data, with Brugada ablation in over 200 patients, they have very high success rates. I don't know if curative is the right word to describe it, but Carlo certainly does believe that this can be curative in some patients. But the success rates are probably higher than we do with scar-related VT. That's for certain. You take a look here as we're moving down. Let's just take a look on fluoro where we are too. And then you can see we're right over the low epicardial RVOT in this region. And then here, signals are more normal in width. So you could obviously do an electrogram duration map. You can do an ILAM map. And then here you could see they're more normal. So I would approach the areas that are the widest. Of course, if we gave procainamide, and we could do a gram over 15 minutes, but we only have about 15 minutes left with you. the question is should we exaggerate as much substrate as possible to be able to widen the target zone? I do think that you can always come back another day too, and doing the entire RV epicardium, which this is pretty expensive, might not be the best thing for the patient. And we don't know how much is enough. It's also important to state that we can never normalize these electrograms. It's not like we eliminate them all. We modify them. And that's where I believe we probably change current density, as the RVOT has the highest density of ITO channels in the epicardium.
Rod, what's the role of warm saline or warm contrast in the pericardium to induce some of these instead of procainamide?
Fevers and high temperatures will exaggerate a type 1. Just like any sodium channel blockers. Cocaine is a classic sodium channel blocker. I remember being with Dr. Brugada in the 90s, and they had like a pseudo Brugada, but it might have been concealed Brugada. So I think anything to exaggerate it, it's more relevant when you don't have a type 1. We have an overt type 1. If this was type 2, I would advocate for procainamide or ajmaline if you're in Europe. But here you can see that we actually have pretty overt phenotype. And this is probably the most beautiful type of electrograms that we're seeing right there, is these broad, wide, complex electrograms. So I would focus the areas over here. The question always is about conus, and do we shoot arteries over here? Most people do not, but obviously you could injure small branches over the RVOT and the conus, which could be catastrophic, knowing that when you intubate the conus inadvertently in cath, sometimes you can trigger VF. The relevance of that is not clear, but I think with broad spread, with a lot of ablation here, we'll probably move quickly at 40 to 50 watts and just move around this target area and see what we can change. And here you can see I'm getting the lateral extent of it. And I would probably just target this middle region that we have and then stay away from the tricuspid annulus where we know the right coronary artery is. So this is kind of where I would start my lesion set here. Connor, why don't we just kind of draw just a general area there of where we would start. Here you could see the electrograms are clearly abnormal. And then I would really probably target, something over to here, all the way over to here. The question is, where's the LAD? And that is relevant as well. The nice thing is with the pericardiogram, we actually can see where the septum is right there. You could see we're over the RVOT live, and you can see that over this direction, if we were to move it over to the septal margin here, this is probably where we start getting closer to the LAD. Right there, you can actually see it, the interventricular groove and the RVOT right in this area. So I would probably just do my lesions here and see what happens with where the grid is right there. That's going to be my target zone right in between the two. So can we get the ablation catheter while we have more discussion?
Rod, quick question. This amount of voltage abnormality is pretty extensive. The electrograms are beautiful. With this, along with that aneurysmal change on eyes, are you more concerned about ARVC now?
I still think there's probably some overlap. There's too many things we don't understand, but the whole phenotype really matches more with a Brugada, given the localized abnormalities here. Can we go ahead and aspirate back here? And I'm trying to see if I can see the grid catheter over the aneurysmal part, if this is the most of it. You can see that we've got some fluid in here in the pericardium that we need to get drained. But I'm happy to report that there's no bleeding from the epicardium, which is good. But I don't think that this is ARVC, because ARVC doesn't present with nocturnal sudden death and VF. I just don't think that's classic. I think this is a classic boards for Brugada syndrome. But I can't pretend to know.
Yeah, and the quality of the electrograms too is more similar to what we see in Brugada syndrome than it would be for ARVC type of stuff, which gives us classic late potentials and delayed activation like that.
As you can see,
Anna,
we're
have to put the
rejoicing in the fact
unipolar-
that this is a very clear tap. So that's good. And we're looking at hemodynamic stability.
Can you put the unipolar endo map and overlap the epicardial map over there? Because we always talk about unipolar map and looking at the epicardium.
Connor, can you show us the endo grid map that was created with voxel and see if it's in this region that we're going to target? It probably is right underneath it, as we would expect, but we'll see once he puts this up. There it is. So it's kind of on the lateral aspect there, Devi. You can see there. It's a nice epi-endo relationship. And then now we're going to go ahead and replace this. Just as a quick word for epicardial care, you want to minimize the time you have an exposed sheath, because Young Hoon Kim and Paula Dovell have taught me that an open sheath is like a straw, and that can lacerate veins and arteries and things. So you want to really keep that vacant sheath time to a minimum. So you can see right there, now we're in with an ablation catheter, and that mitigates some of that risk. And as we approach this area, you know, the technical aspects of this are not challenging, right? Anyone can go ahead and put the ablation catheter there and deliver some lesions. It's about how much to do, what the endpoint is. Why don't we go to a 12-lead EKG and just the ablation catheter? And I think it'll be exciting to monitor the response to ablation. And typically you'll see really large ST elevation. My sense is that there's some ITO channel stuff that really changes with it. Or it's just an injury pattern across the RV epicardium. But we're going to monitor some responses. Let's do 40 watts and see what happens there. We're going to start here and go ahead and deliver a lesion. We got about 10 minutes left in our case. Yep, let's go ahead and do 40 watts right here. And we want to see if the electrograms change and if there's any abnormality here. And because there's a lot of fat and electrograms don't change, I would be quick to ramp up. But there you see there's some queuing out of some of the local, which is great. I'm just going to go ahead and move on the fly here. Let's go to 45 watts. We typically go to 45 or 50 on the epicardium here. And this doesn't have to be an all-day affair here. We're just doing a small postage stamp area here at RVOT. Granted, it's a little bit more extensive. Look at the elevation in V2 right now. You can see live the elevation in V2. Why don't you go ahead and show the live? Actually, you've got the live screen on the upper right there, Chris. That looks fine. We're going to move a little bit here and just make sure that electrograms are changing in this area. I'm trying to get this deflected towards the epicardium and use the arrow a little bit more there. But here at, go to 50 watts here. Yep, you can see there's kind of these far field signals. I'm suspicious that I might be over some fat here as well. We do have some more ST elevation there in V2. Can you measure the height of that ST elevation? I measured at 3.5 before, but now it's much higher. Keep going, keep going, keep going, keep going. So it's like 4 point more to the top of it. That's good, 4.5. So it went up a millimeter. Nothing crazy over our baseline, but you can see there, it's really tombstoning in V2. Very characteristic response. Take a look at V2 right now in live screen. That's great. I'm just kind of moving around in this region here. I personally think there might be some leakage of ITO channels as you're ablating this, and you're seeing some unopposed ITO here that's creating this J wave. But this is a fantastic thing to see. Obviously, it's scary when you see ST elevation and then V1 and V2. But you can see I'm just moving around here. Electrograms are getting a little bit lower in amplitude when I'm kind of remapping over the region. Now those STs have improved. So it is transient phenomenon. I don't know if it's current leakage, but there's got to be something that's happening. And we don't see ST elevation when we ablate other types of scar-related VTs. So I do think there's this something different. I'm in the lower boundary. These signals look relatively simple now, down in the inferior margin. And I'm just going to move over here with the last 7 minutes of this case here, Richard, over to this other side, and we can pause for a moment too. But there you see a little bit more ST elevation, filling in these regions, really staring at electrograms and seeing if we've made an impact. We could obviously remap as well. Here's more over the actual RVOT. But the signal's right there. If you look at ablation distal, why don't we go live screen only and focus on EGM? Live screen large, Chris. The signals look a little bit more simplified here. It could be wishful thinking, but that's the only way to live. And here, you see here, these signals do not, so I'm kind of remapping as I'm ablating, scanning regions over this small area. And I'm not seeing too much here anymore. And it might be fun to run a grid if we get a little time, but why don't we get some responses from the panel about what we're doing here and how we're doing.
Yeah, I mean, I think it's very impressive, Rod. I think the delay is disappearing. The ST segments have definitely gone up, and now they've come down again. They look like they're popping up again a little bit there. So there's definitely an impact on the tissue that you're having there. There's no doubt.
Absolutely.
How
I
much
wonder
of
if it
this
could even be.
ablation has to be I was going to ask, how much of this ablation has to be transmural for you to have the effect to be durable?
I actually don't think
Look at
it
those
does.
tissues.
I'd be
Measure that.
interested to know what Rod thinks about that. But I think that there's the implication is that the substrate for this is very, very superficial. And the cases that my N is only like 4 also. So, but it seems to be quite easy to interrupt those areas. It doesn't require like huge long lesions to do it.
It's definitely 4 times more than
So I agree with Usha. It's something very localized here. The really cool thing is this is our first case of Brugada in the 4 years I've been in Phoenix. And, you know, we've done several in Asia, you know, with different reports of it. We had about 4 at University of Chicago. So if you cumulatively look at it, the experience is not large in the U.S. And of interest, this patient is actually of Mexican and Spanish descent and has some Native American indigenous lineage as well, but is definitely not the classic one at all as well. And I don't want to under-ablate this, but I don't want to over-ablate this. So I'm just going through here again, and you can see these signals look relatively simplified right here. I'm just kind of filling in this area. They look very far field, less complex. We can throw a grid up there, but Richard, I'll let you call the time here. But I think I'm about done with the ablation here. This looks like a lot of ablation, but as you can see, we're kind of ablating 15, 30 seconds and moving around.
Yeah, I think we're out of time. My team tells me that we're out of time here, Rod, but it's been an amazing case. I'm so grateful to the panel for their great inputs. And your team can't hear me, Rod, but perhaps you could pass on the message that the whole world has been watching you and them and have been very impressed with both cases, and particularly how efficient they are and how quickly they turned over the cases. So we're very grateful for their efforts.
Well, we are so grateful for the opportunity. Thank you to the whole team. It's been an incredible day for us. And again, grateful to be part of this incredible global showcase.
Great. Well, that's the last session of the day. Our day summary is coming right up. And thanks for staying with us. And thanks to all of our brilliant panelists and clinical case presenters.